What's up, Ninja Nerds? In this video today, we're going to be talking about antifungals. As I've said before, with the antibiotics, antivirals, lots to cover. Not as much as when we talk about antibiotics and antivirals, but it's still important. It's a pretty cool topic, that being antifungals. Go to our website, down we'll have a description, link down in the description box below. Go check that out. We'll have some really awesome illustrations, some great notes for you guys to follow along with me during this lecture. So let's start off first when we talk about antifungals. How do they work? So we have a fungal cell here. A lot of these drugs, they have a very, very interesting mechanism of action, and it's actually straightforward. So when we talk about these, we're going to talk about these top three, then we'll sit down, we'll come talk about the bottom three down here. But generally, there's a couple drugs. One of the first ones that I want you guys to remember is, inside of our actual fungi, they have a nucleus. In order for the nucleus to be able to undergo the division process, for the fungal cell to divide, make more fungal cells, it utilizes these things here called microtubules. So you see these things right here? These guys right here are called your microtubules. Now, microtubules are obviously super crucial to the cell division process. What if I had a particular drug that can bind onto the tubulin proteins that make up the microtubules and inhibit it from being able to allow for the cell division of fungi to occur? That'd be pretty interesting, right? And that would be a good antifungal. We have a drug that's called griseofulvin. So griseofulvin will actually bind to the tubulins in the microtubules and inhibit the microtubule function. And what will this lead to? This will lead to decreased cell division. So the fungal cell will not be able to divide. So that's one particular drug. So I want you to remember griseofulvin inhibits the microtubules by preventing cell division. It binds to the tubulin proteins and inhibits the microtubular function. Boom, griseofulvin, done. All right, flucytosine. This one's a little interesting, a little funky, a little weird, but it's a cool anti-metabolite drug. So how this drug works is, inside the nucleus of the fungal cell, we have DNA, right? DNA is obviously responsible for being able to, what is this called? If you take DNA and you make more of the DNA, that's called DNA replication, right? So we take DNA, make DNA. But if we take DNA and we make RNA, so a single-stranded that we're going to utilize to make proteins, this is called transcription. So flucytosine is an interesting drug. So what happens is flucytosine gets taken up into the fungal cell. When it gets taken up into the fungal cell, it gets acted on by an enzyme here. I don't want you to work too much to remember this one. I'm going to abbreviate it. It's called cytosine deaminase. What cytosine deaminase does is it actually converts flucytosine into a drug called 5-fluorouracil. Get your minds clear. So what happens is 5-fluorouracil is a very interesting drug, or metabolite here, where it can actually bind to specific components of the nucleic acids and inhibit them from being able to function properly. So subsequently, it'll inhibit DNA replication and it'll inhibit DNA transcription to make RNA. If you can't replicate DNA, will the actual fungal cell be able to divide and pass on its nuclear machinery? Will it be able to make fungal proteins that are essential to its function? No. So flucytosine would be able to, again, inhibit DNA replication and DNA transcription by being converted into a metabolite called 5-fluorouracil, 5-FU, okay, and then inhibiting that type of function. So that's one of the other drugs, flucytosine. All right, boom, roasted. Next one is echinocandins. Now, echinocandins are a really cool drug category. So when we talk about these, there's actually a couple different ones. If you really can't remember the names of them, that's okay. I want you to remember that echinocandins always end in fungin. Pretty original, right? So fungin. So two big ones that you'll probably see, micafungin. This is the one that I have at my shop at the hospital. And then there's another one called caspofungin. There's also another one as well, but these are probably going to be the most commonly utilized fungins that you'll see are the echinocandins. Now, these drugs are really interesting. You see this cute little enzyme here, this little bird enzyme? This guy here is called a beta-1,3-glucan synthase. You're like, what the heck? This cool little dude right here, what he does is he takes specific types of carbohydrate molecules and converts them into a molecule called beta-1,3-glucan. I bet you couldn't figure that out by the name of this enzyme name. But what it does, it actually takes and makes these particular molecules called beta-1,3-glucans. And there's other components here in the cell wall, beta-1,6-glucan, but this structure here is integral to the actual cell wall. And what do we know about cell walls? Cell walls are supposed to provide, and generally in these fungi, resistance to osmotic forces. So generally, if it's providing good resistance to the osmotic forces, imagine I give a drug called echinocandins. What do you think it's going to do? It's going to inhibit this beta-1,3 glucan synthase? Will it be able to take carbohydrate molecules and incorporate into beta-1,3 glucan to incorporate into the cell wall? No. So we have a decrease in the beta-1,3 glucan, and the cell wall activity will now be hindered because there's now going to be decreased resistance to osmotic forces. And this fungal cell is all kinds of jacked up then. It's going to end up undergoing cell death by cell lysis processes. So that's this type of drug category. So far we got griseofulvin inhibits the microtubules, right? We got flucytosine forms a metabolite called 5-FU, which inhibits DNA and DNA replication and DNA transcription. And then we have the echinocannins, the fungins, microfungin and caspofungin, which inhibit the beta-1,3 glucan synthase, inhibiting the glucan molecules that are important to the cell wall, resisting osmotic forces. Now you get rid of that, you don't have strength against osmotic forces, boom, the cell can actually undergo lysis and die. All right, we're not done. Now we got to come on to these bottom 3 drugs here and talk about them. All right, so the next thing, when we talk about this next drug called terbinafine, it's actually pretty cool, but we have to go through a little pathway. So when we talk about the pathway within inside of the fungi, there's a very important component here. You see these like green structures here? It's called ergosterol. Let's actually write that up. So this molecule here is called ergosterol. So ergosterol. Now, ergosterol is kind of like a cholesterol molecule, if you will. So what happens is in order for us to be able to make this, first off, it plays a role within the stability of the cell membrane. So stability of the cell membrane is the primary function of ergosterol, which is a cholesterol-like molecule. We know that. Generally, cholesterol plays a big role in cell membrane stabilization, especially with like temperature and pH changes, etc. So we need to make ergosterol in order to incorporate that into the cell membrane to provide stability. How do we make it? So you start off with a particular drug called squalene. So squalene, such a funny name, gets acted on by a very specific enzyme called squalene epoxidase, which converts squalene into, what do you know, squalene epoxide. Then squalene epoxide is then converted into another molecule called lanosterol. And then lanosterol is then going to be converted into ergosterol via this other enzyme, and then we'll talk about that one right there. All right, so we have this kind of pathway here, if you will. So squalene to squalene epoxide is acted on by, it's actually, particularly this reaction occurs based upon the presence of this cute little blue enzyme. What's this cute little blue enzyme called? This blue enzyme here is called squalene epoxidase. So it's called squalene epoxidase. And this drug here, called terbinafine, will actually inhibit the squalene epoxidase. If you inhibit squalene epoxidase, you reduce the conversion of squalene to squalene epoxide. Then, if you reduce the production of squalene epoxide, you don't make as much lanosterol. If you don't make as much lanosterol, you don't have as much ergosterol. If you don't have ergosterol, you have decreased stabilization of the cell membrane. Therefore, it's at risk of the fungal cell dying. That's an important process here. So terbinafine inhibits the squalene epoxidase, inhibiting ergosterol synthesis, important for cell membrane synthesis. So far we got griseofulvin, microtubules. Flucytosine inhibits DNA and RNA synthesis. Echinocannins inhibits beta-1,3 glucan synthase. And then terbinafine inhibits squalene oxidase. Okay, we got another one. Obviously, it's this cute little guy here. This one here, it's got a heck of a name. So we got all this space here. It's called, and it's specifically going to stimulate this particular process. This is called the CYP450 14 alpha demethylase. Oh my gosh, that's such a long name. But this enzyme is responsible for converting lanosterol into ergosterol. So if I give a particular set of drugs called azoles, the azoles will inhibit the CYP450 14 alpha demethylase, which is basically going to reduce the conversion of lanosterol into ergosterol. If there's less ergosterol, there's less stabilization of the cell membrane and more likely for the cell to be able to die. That is the process of these two drugs. So if you want to know for the actual synthesis of ergosterol, there's two drugs. One inhibits squalene epoxidase, that's terbinafine. One inhibits the other enzyme, CYP450 14 alpha demethylase. That's your azoles. Now, azoles, there's a couple of these drugs. One is called your triazoles, and one is the imidazoles. Okay, with these, your triazoles are very potent, very powerful drugs. So you can remember what's called voriconazole as one of these. You can remember what's called itraconazole, for this one. And you can remember isovuconazole. These are very, very powerful drugs. Another one here is called posaconazole. This one, we don't see too much. It may be used in like prophylaxis in certain situations. But this last one here is another big one that you guys have probably heard. It's called fluconazole. Fluconazole. So these are your triazoles. So your triazoles are going to be voriconazole, itraconazole, isovuconazole, posaconazole, and fluconazole. For the imidazoles, these are less of those potent agents. And this is going to be something called miconazole, clotrimazole, and the last one here is called ketoconazole. All right, and we'll talk about all the functions, like which ones, what kind of infections does these cover versus what these cover, and et cetera, with all of these. But I just want you to have an idea about the actual azoles and mechanism of action. Okay, we got the mechanism of action done now. We know that these are inhibiting the ergosterol synthesis, which is important for cell membrane stabilization. There's one last drug category here, and these are called polyenes. Now, polyenes are very, very interesting. So if we take a look, let's say that we actually zoom in on the cell membrane at this level here. So what we're going to do is we're going to take this kind of portion here and we're going to zoom in on it really, really well. And we see here we have our cell membrane. So all of this component here is going to be the inner cell membrane of the actual fungus. And then here we're going to have our ergosterol molecules here. Here's our ergosterol molecules in green. What happens is you have this drug which are called your polyenes. Polyenes are really cool because what they can do is they have two different types of like surfaces on them, if you will. One of the surfaces is going to have a surface where it can actually bind to lipid molecules. So one surface is actually going to be loving to bind to the lipids. So it's the lipophilic surface. The other surface of this molecule actually wouldn't mind interacting with water and other kinds of like water-soluble molecules. So it's more of a hydrophilic molecule. So because of that, it binds kind of perfectly like this. So this lipophilic end here, I kind of like draw it like this, is going to bind perfectly with this green ergosterol molecule. And it's going to do something like this. Look at this. So here's the lipophilic end, and then here's going to be the hydrophilic end on the other side. Same thing. Here's another one of these actual molecules here, our polyenes. One surface is going to love to bind to the actual ergosterol because it's lipophilic, and the other one doesn't mind interacting with water molecules, so that's going to be your hydrophilic end. And it's going to look like this. Now, if you kind of imagine what this does, this makes kind of an interesting like type of pore molecule, and it puts it into the cell membrane. So now I have a pore inside of the fungal cell membrane. The problem with that is that now I can have different types of ions moving in and out of this actual fungal cell, causing a lot of electrolyte imbalances and increasing cell lysis and subsequent cell death. So what are the drugs that actually can form these pores inside of the actual fungal cell membrane, causing electrolyte disturbances because one side of it can bind with the ergosterol, the other side can interact with water? These are your polyenes, and there's two particular drugs here. One is called amphotericin B, and the other one here is called nystatin. And again, we're going to talk about all these actual drugs and what kind of like functions they have. Now that we talked about the mechanism of action, let's move into what are the clinical usages. All right, so now we're going to talk about the clinical usages of these antifungals. So there's a lot of different fungal infections that we'll go over. And we'll kind of go over like which particular areas that you see these types of fungal infections in. We're not going to go crazy in detail because we'll cover these fungal infections, like each one specifically, like candidiasis and aspergillus, in like the actual infectious disease section. But for right now, let's say you have a patient who has candidiasis, and it depends upon where the actual candidal infection is that determines which antifungal we will pick. If it's in the oral cavity or near the pharynx, they have like the oral thrush, or they have some candidiasis near the actual pharynx or tonsils, what are you giving them? Generally, nystatin tends to be the actual preferred agent. Now, nystatin is super powerful if you give it intravenously, so we cannot give it intravenously. So generally it's more of a topical agent, or you can actually put it in the mouth, swish it up, and then swallow generally. That's going to be the preferred function here in oral pharyngeal candidiasis. So we can do nystatin, but it's important to remember that this is not going to be an oral nystatin, it's not going to be an intravenous. It's generally going to be, this is no joke, we actually say swish and swallow for the actual nystatin. The second agent that we can also use is clotrimazole, but particularly it's like a lozenge. So it's not really an oral like agent, it's actually more of a lozenge that we can have the patient kind of have and like dissolve over time. So the other agent that you could utilize, and clotrimazole, which one was that? Was that the actual imidazole or the triazoles? It was the imidazole, along with miconazole and ketoconazole. So clotrimazole would be the other agent here that you could utilize. And this is going to be like in a lozenge kind of form. So these would be the two agents that we utilize for oropharyngeal candidiasis. Now, let's say that actually gets into the esophagus. If it gets into the esophagus and start causing like esophageal lesions there, what do we use for this one? This one's generally oral fluconazole or itraconazole. That's one of your triazoles. So in this one, we can do fluconazole, or we can do something called itraconazole. But it's important to remember for these ones, we need a little bit more systemic involvement. So these are both going to be PO, oral, okay? Next one is vulvovaginal candidiasis. So if someone develops a nasty vulvovaginal candidiasis, what do we utilize for this one? So you start off with topical azoles. And this is not the triazoles, this is the topical imidazoles. So topical would be the preferred type here for meconazole or clotrimazole. So you try this as the first line agent. If they do not respond to that, then you do something called fluconazole. So this is going to be PO. And if they don't respond to that, you could add on that drug called flucytosine. Do you remember what flucytosine did? Flucytosine was that 5-FU molecule, inhibits the DNA RNA type of activity, whereas the azoles are inhibiting the CYP450 14 alpha demethylase. And then the statin is the polyene, forms the pores. Just trying to see if we can go back and remember these things. All right, so we got oropharyngeal, esophageal, vulvovaginous. What about intertriginous type of candidal infections? So this is where you have very, very moist areas where sometimes that moisture can allow for candida to kind of just thrive in. Generally, this is the axillary and the anogenital area. So in the axillary or the anogenital area where there's lots of moisture, this can be an area where candida can thrive. And generally, nystatin as a topical agent would be the preferred type of agent that we would utilize in this infection for intertriginous candida. So far we've covered oropharyngeal, we've covered esophageal, we've covered vulvovaginal, and the last one, or the almost last one, is the intertriginous one. We now need to talk about the worst case scenario. What if the candida gets into the bloodstream, becomes more systemic, or causes a lot of deep infections that are not mucocutaneous? In that situation, we're getting into candidemia, candiduria. What do we do for that? Let's come down and talk about that. If you have a patient who has systemic candidiasis, there's likely, generally in most fungal infections, like systemic fungal infections, there's likely immunosuppressed in some way. So transplant, HIV, have severe diabetes, something that's really making their immune system severely depressed that allows for these kinds of fungi to cause nasty infections. If a patient ends up with like nasty systemic infections, so they have like, for example, candida causes like endocarditis, and that's a possibility. Sometimes you can see endocarditis, or you see like really nasty like bloodstream infections. Another one is UTI, so genital urinary candida, or believe it or not, ocular candidiasis. You can actually get infections of the eye with candida, so some type of ocular involvement. But I think the big thing is that it's disseminated. Let's use the term maybe systemic or invasive. It's really starting to involve other organs, and it's not just at the skin level now. It's actually gotten to the bloodstream and spread to other areas, or it's involving deeper organs. In those situations, the preferred first-line agent is echinocandins. Do you remember the echinocandins? The echinocandins was your fungins. This was your mycofungin, your caspofungin. What did it do? It inhibited the beta-1,3 glucan synthase. I know you guys knew that. But let's actually put that this is the first line. Other agents that you can consider as an add-on, it just doesn't cover all the candida species, it covers a good chunk of them though, is fluconazole. And again, this has to be PO. And then the other one would be amphotericin B. So amphotericin B is another potential option here. Sometimes they will say that you should add on another agent like flucytosine to that one, but generally amphotericin would kind of be the last line. So generally you'll start off with the echinocandins first line. If that doesn't work, fluconazole, and then generally amphotericin. But again, important to remember here for the systemic invasive infections, if somebody says which one do you treat with first, it's always echinocandin. So I would actually try to remember that one significantly. Fluconazole would be kind of your second line agent. Amphotericin or amphotericin would be kind of like the last line for these. All right, we talked about candidiasis. Let's now move into the other fungal infections. All right, so let's talk about aspergillus. So this is an interesting type of like mold infection. So When we talk about Aspergillus, it really tends to particularly involve the lungs, all right? So primarily the respiratory system. It starts off kind of like causing like a little bit of like a pneumonitis or like a bronchopulmonary like involvement, but then it can actually cause the trachea and really cause like a necrotizing tracheitis, then extend down. And if somebody prior had like a TB and they had a cavity here, from the TB, the actual fungus can hop into that and cause like a really nasty like fungal infection there, almost like a fungal ball. Not even kidding, it's called an aspergilloma. And sometimes from here it can actually disseminate. So it can really cause the lungs, wreak a lot of havoc on the lungs. So generally when somebody has some type of Aspergillus infection, we treat them very intensely for invasive aspergillosis. So preferably, the first line agent in Aspergillus is going to be voriconazole. So voriconazole will always be the answer as the first line agent. Second one would be the isovuconazole. You could consider that one. If they can't take the voriconazole for some particular reason. Another agent is echinocandins. Echinocandins are also very good at covering your invasive aspergillosis. The last one I would say would be really like if you really need to because they're refractory to all the above things would be your amphotericin, but that would be pretty much your last line. So I would actually remember your voriconazole first line, isovuconazole also has some pretty good coverage, and then echinocandins. Last one for severe refractory cases, you can consider amphotericin B. The next one here is Cryptococcus. It's kind of like a yeast-like species, if you will. And it really loves to kind of harvest here in the lungs and cause a lot of like pneumonia, but it also can spread to the meninges and cause a really nasty cryptococcal meningitis. So whenever we're covering Cryptococcus, it's a two-part therapy. There's the induction, kind of like the first 2 weeks that someone's actually been diagnosed with it. So in the first 2 weeks of diagnosis, we actually do a two-part combo. We do amphotericin B, and then we add on here what's called flucytosine. So we do this for the first 2 weeks. Then after that, as a maintenance therapy after those 2 weeks, we then can keep them on something called fluconazole. So then it'll just be fluconazole and we'll drop the amphotericin B and drop the flucytosine. All right, so that'd be Cryptococcus. So far we got Aspergillus, we got Cryptococcus, and we covered all the candidiasis. Let's come down, talk about our endemic fungi, and then we'll talk about the really nasty mucormycosis, and then some dermatophyte infections. All right, so the next one, blastomycosis, histoplasmosis, coccidiomycosis. Generally, these are endemic, so they're dependent upon the geographical area that's a little bit beyond the scope, so we're not going to go into that. I would just want you to know, if you have a patient in their vignette, they're diagnosed with blastomycosis or histoplasmosis or coccidiomycosis, these can involve tons of organs. So generally, most of them, at least 70% of the time, always are going to cause some type of pneumonia involvement. They may even cause some type of meningeal involvement, especially histo and then coccidio. You can see a lot of skin kind of involvement, a lot of like skin and bone lesions, particularly in blasto and histo as well. So either way, you can see a lot of different types of involvement. Primarily, always going to involve the lungs, some type of meningeal involvement, and skin and bone lesions. In these situations, if the patient comes back positive for these particular type of fungi, how do we treat them? The preferred agent, some of the evidence is saying that itraconazole may be superior. But another drug that you could utilize is fluconazole. So if you have an option between these two, I would actually go with itraconazole. It's actually believed to be more superior than fluconazole, but fluconazole is also a decent option. All right, if these two particular drugs aren't available, or for more specifically, if you have a severe refractory case of blasto, histo, or coccidio, you can consider amphotericin B. But this would be, let's actually put this down, amphotericin B would be more for severe kind of refractory cases, really. But the preferred agent, remember, itraconazole. So again, Aspergillus, voriconazole, crypto, two-part, ampho, flucytosine, then fluconazole, blasto, histo, coccidio, itraconazole first line. And then you can consider fluconazole ampho if it's severe. The last one here is mucormycosis. So this is a type of mold, and it's a really nasty one. I actually would think that you guys should remember that you can see this particularly in patients who have diabetes, especially if they have like a diabetic ketoacidosis. So whenever a patient has diabetes mellitus, they definitely have like a little bit of immunosuppression. And this actual kind of mold can cause a lot of infections of the sinuses that can actually sometimes extend up into the actual brain tissue. And so it can cause kind of like a really nasty rhinocerebral sinusitis. Okay, so you can get a really nasty type of sinusitis here. They can actually cause black eschars to form within the tissue. Sometimes you have to debride. So really nasty sinusitis, and then sometimes it can even spread into the actual lung tissue and cause a pretty bad pneumonia. So if somebody has mucormycosis, look for a patient who has diabetes in the clinical vignette. Look for really nasty black eschar-like sinusitis. also look for pneumonia involvement. What do you use to treat these patients? Generally, isovuconazole is going to be the first line agent. If that one isn't available, you can consider, or they have some type of contraindication to getting an azole, like a severe hepatotoxicity of some particular region, you can consider amphotericin B, if there is some particular contraindication to the above here. But oftentimes, because of these nasty, like infectious lesions, you also sometimes have to debride the lesions as well. So I'd also, don't forget, it's a little bit beyond this lecture, but just remember that that's not the only treatment is the antifungals. Sometimes you may need debridement of the actual lesions as well. All right, that covers these particular nasty systemic fungal infections. Let's kind of finish it off with the easy, commonly remembered ones, which is your dermatophyte infections and tinea versicolor. All right, so the next one, tinea versicolor. So these are like these hypopigmented like lesions here that you can sometimes see like on the actual body, like on the trunk. And generally with tinea versicolor, it's always going to be a topical agent. Preferably, you can try something like a topical azole, but these would be your imidazole. So ketoconazole and meconazole tend to actually be the preferred in these situations. So you would do something like a topical, and with these topicals, you would do something like meconazole, but actually preferred seems to be ketoconazole. So I would actually remember ketoconazole as the preferred agent in this condition. So I'll kind of put like an asterisk there for that one. All right, tinea versicolor, done. The last one is your dermatophyte infection. So these are also your tinea infections, but we don't consider tinea versicolor to be a part of this one. So with the dermatophyte infections, it actually depends upon where, so these are like your superficial fungal infections, and it depends upon where the actual infection is that determines what kind it is. So really quickly, if it's kind of like generally like near the head, we call that tinea capitis. And then if it's occurring kind of like near the, generally like near the beard region, we call it tinea barbae. If it's near the actual body, we call that tinea corporis. If it's occurring near the actual growing region, we call that tinea cruris. If it's occurring near the actual feet region, so like an athlete's foot, we call that tinea pedis. And the last one is if it actually involves the toenail and causes some actual fungal infection of the toenail. We have two names for it. It's called tinea unguium, but oftentimes you'll see onychomycosis as the actual common name that you'll sometimes see too, or tinea unguium. So generally, these are the types of infections that we can see. Now, with all of these, regardless of which type it is, tinea capitis, tinea corporis, tinea cruris, tinea pedis, we can treat all of these pretty much with the same particular agents. So what are those agents that we would utilize for these infections? So generally, the preferred agents here is you start off with the topical azole. So topical agents would kind of be the first thing that you would try. And so this would be, again, your meconazole. This would be the clotrimazole. This would even be attempting the ketoconazole. If these don't work as the first, then the second thing that you can attempt to is something like a oral itraconazole. So oral itraconazole would be another particular agent here that you can try. The other thing here that we can sometimes see utilized is griseofulvin. So griseofulvin may also be utilized. That's kind of like your last line agent though. So I'd say your topical azoles, then an oral itraconazole. If that doesn't work, griseofulvin. The last thing here is for onychomycosis. For onychomycosis, the only particular treatment that we see best suited for onychomycosis is something called terbinafine. So this would be the only times I would actually see this drug really being utilized is terbinafine. Sometimes they say griseofulvin, but terbinafine is obviously way more superior in onychomycosis than compared to griseofulvin. Okay, so far, we've covered all of the different types of fungal infections that we would use antifungals for. Now that we've gone through that, the next thing that we have to be aware of, okay, we put these patients on these antifungals and they are at risk for what types of adverse effects. So what kind of things should I be monitoring, looking for? Which would make me want to not pick this drug and pick another drug depending upon their clinical history and medications that they take? Let's talk about that. All right, so let's talk about the adverse effects of these antifungals. So the first one is amphotericin B. So we obviously use the funny little term amphoterrible. Just there's a lot of adverse effects that we got to be careful of. So one of the big things that is extremely nephrotoxic. So you have to be careful. Monitoring the patient's renal function is very, very critical when you're giving this medication. Okay, so amphotericin B, remember it has nephrotoxicity. So you want to be monitoring the patient's renal function when they're taking this drug. All right, the next thing is if you give this drug, it has the ability to cause a lot of inflammation and irritation to the actual blood vessels whenever you infuse it. Sometimes it can even cause fever and chills during the infusion of it, but it can cause phlebitis. So kind of inflammation and irritation of the actual blood vessel. The next thing is it can actually suppress the bone marrow, particularly preventing the formation of red blood cells. So you may see a patient drop their red cell count when you do a repeat CBC, so you may see anemia. Here's the other thing. It also can increase the risk of arrhythmias, tachyarrhythmias. So particularly what it does is it actually leads to low potassium, and it also can lead to low magnesium levels. And this can actually increase the QT interval and put a patient at high risk of something called torsades de pointes. So it's important to remember here that there's nephrotoxic effects, phlebitis, and sometimes even fevers and chills during the infusion, anemia from bone marrow suppression, and lowers your K and MAG, which can increase your QT interval and cause torsades de pointes. All right, what about terbinafine, since we're already here? It can jack that liver up. There's a pretty common thing that you're gonna notice from a lot of these drugs other than amphotericin B. So that'd be kind of maybe one of the reasons someone has like a very acute liver failure, or they have terrible bumps in their LFTs, and you're trying to figure out, okay, which one should I put them on? Well, they already have like almost acute liver failure. Probably shouldn't put them on some of these other drugs. Amphotericin B may be a little bit of a better option. But terbinafine, if you're treating somebody with onychomycosis, what would terbinafine potentially need to monitor? You'd need to monitor their LFT. So it is have the ability to cause hepatotoxicity, so you can see a bump in their LFT. So monitoring that while they're on the drug. The other thing is it can actually cause change in taste. So a decrease or loss of taste, and we call this dysgeusia. Such a seductive like name, but dysgeusia for terbinafine. All right, the next one here is echinocandins. Echinocandins are going to be your caspofungin, micafungin, albuminofungin, and these two drugs, those two categories of drugs, particularly micafungin, caspofungin, most commonly utilized, are going to cause hepatotoxic effects. So you notice the common theme: terbinafine, echinocandins, probably all the other ones here are going to cause hepatotoxic. So you're going to want to monitor their LFTs during this. Here's the other thing: echinocandins like caspofungin and micafungin, when you're giving the particular drug, it may activate certain mast cells in the skin and cause a release of histamines. So particularly during the infusion of this drug, it may cause a histamine response that causes kind of a vasodilation of the actual blood vessels near the skin, which can lead to a flushing type of reaction. So you may see a lot of flushing during the actual administration of these particular drugs. So watch the LFTs and watch for any kind of flushing. All right, now let's come down and talk about the azoles, griseofulvin, and flucytosine adverse effects. All right, so next thing, azoles. Azoles, so again, this is your imidazoles, your triazoles. When we talk about these drugs, I kind of focus a little bit more particularly on the triazoles, so especially if you're giving them systemically, so fluconazole, itraconazole, isobuconazole, posaconazole, and voriconazole. Not so much the actual ketoconazole, although you can give ketoconazole orally, especially in certain situations. If you do give it orally, you can see some more systemic side effects. But usually with the topical formulation, you don't see with meconazole and clotrimazole, you don't see a lot of the adverse effects. So I'd remember a lot of this, you're particularly going to see it more with the oral agents, but don't forget ketoconazole can be given PO, and you'll see two particular adverse effects from PO ketoconazole. So azoles in general, especially the triazoles, remember that it is hepatotoxic, so you're going to want to watch and monitor their LFTs when you put them on this drug, because you can see a bump in that. Here's the other thing. A lot of these azoles are CYP450 inhibitors. So they're CYP450 inhibitors. And so what that means is if you take a particular drug, it actually metabolizes it by adding on particular molecules like glucuronate and different types of molecules to make it a little bit more polar. But it's involved in drug metabolism. If we give one of these azoles, it actually will increase the actual concentration of the drug. So you'll have an increased concentration of the actual drug. So for example, let's say that you're having a patient who's taking warfarin and you put them on an azole as well. The azole can inhibit the CYP450 enzyme, inhibiting the metabolism of particularly the warfarin to make it a little bit more polar, but it actually increases the concentration of the total drug within the bloodstream. So now they're at higher risk of bleeding. The next thing is particularly with ketoconazole, it actually can cause gynecomastia. So particularly ketoconazole, you may see the effect of gynecomastia. This is a little bit more specific to ketoconazole. The other thing is it can actually increase the risk of arrhythmia. So it is slightly pro-arrhythmogenic because it can cause low K levels. And that low K levels may actually prolong the actual QT interval slightly. And if you increase the QT interval slightly, there is a slight increased risk of torsades de pointes. The other thing is that ketoconazole is very interesting because it is involved in some of the steroid synthesis pathways. Because of that, because it has actually worked, remember we said squalene to squalene epoxide and then to lanosterol and ergosterol, that's all making a steroid molecule, ergosterol. Well, ketoconazole can actually affect some of the actual steroid synthesis within the body. The same way that it works in fungi, it can work in the human body and can inhibit the production of particular hormones such as like cortisol and aldosterone. And so you can actually develop an adrenal insufficiency if you have PO ketoconazole. So remember that. Sometimes we actually use that in treatment whenever patients are making too much of those hormones. So ketoconazole may cause adrenal insufficiency. We're going to put down arrows there. But I want you to remember this is particularly to ketoconazole. The last one is going to be visual dysfunction. So it can actually cause visual dysfunction, visual disturbances. And this is more specific because I want you to remember visual dysfunction. You see the voriconazole is the more particular agent. Visual dysfunction, voriconazole is going to be the most particular agent that has been shown to cause, it actually can lead to reversible visual dysfunction. But so if your patient has this kind of like visual dysfunction when they take voriconazole, you can just either decrease the dose or remove the medication if they can't tolerate it, and then they'll have complete gain of function back of their eyes again. But these are the medication adverse effects that I want you guys to watch out for with the azoles. The griseofulvin is the other one, and this is why we kind of switched to terbinafine generally in comparison to griseofulvin for like onychomycosis and a lot of the dermatophyte infections. You use other agents like your azoles or your topical azoles or your oral azoles. Griseofulvin is pretty hepatotoxic. That's one thing. So you definitely, because of that, you want to monitor the patient's LFTs. To be honest with you, it's probably not a bad idea if a patient asks, if you're asking the question, what kind of labs would you want to monitor in a patient taking antifungals? Measure the LFTs. You probably won't go wrong, to be honest with you. The other thing is, azoles are CYP450 inhibitors. This bad boy is a CYP450 inducer. So meaning it actually is going to decrease the concentration of the actual drug circulating. So if you have a patient who's taking warfarin and you give them griseofulvin will act as an inducer, reduce the concentration of the warfarin, making them less able to, well, actually in this situation, if you decrease the concentration of warfarin, now they can actually clot. So that's the problem with that one. So think about that with other drugs that they may be taking and maybe reducing the efficacy of those particular drugs. The next thing is it's teratogenic and carcinogenic, so do not give this to people who are actually pregnant. So that's one particular thing to remember. And also, if you really want to add this one in, you have the brain space, is it also has been shown to cause a disulfiram reaction, so it can cause that kind of like nausea, vomiting, flushing, maybe even hypotension when you take this with alcohol. The last particular drug here is flucytosine. So just like griseofulvin is teratogenic, flucytosine is also teratogenic. So don't give this to patients who are pregnant. And the last thing is it can actually suppress the bone marrow and prevent the production of all cell lines. So it can drop the production of your white blood cells, and it can drop the production of your red blood cells, and it can drop the production of your platelets. So what do we call that whenever actually you drop all the actual cell lines? Both the white blood cells, the platelets, and on top of that, the red blood cells. This is called pancytopenia. So watch out for pancytopenia, so monitor their CBC whenever you have a patient who is on flucytosine. All right, my friends, I know you think that that's it, but we're not done. We got to review this stuff because there was a lot that we covered. So let's actually do some cases, see if you guys can remember all this stuff, and let's get at it.
What's up, Ninja Nerds? All right, so let's go ahead and do some cases here. We got to talk about some antifungals. All right, so your infectious disease attending is performing his rounds, and he decides to say, okay, I'm going to ask you some questions about antifungal therapy, and let's go through their mechanism of action. So he's going to pimp you out a little bit, quiz you. He says, okay, which drugs inhibit the squalene oxidase, reducing the formation of lanosterol and ergosterol, thereby reducing the stability of the cell membrane? Do you guys remember this? You have squalene to squalene epoxide to lanosterol to ergosterol, which is important incorporating into this cell membrane stability. So if I give a drug to inhibit the squalene oxidase, this would be terbinafine. The next one would be, which is the drug that inhibits this cute little enzyme? So let's go to that one, which is the one that inhibits the cytochrome P450 14-alpha demethylase enzyme. This is going to be, which one? Do you guys know? The azoles. So this is your triazoles, voriconazole, itraconazole, isovuconazole, posaconazole, fluconazole, and then your imidazoles, which is meconazole, clotrimazole, and ketoconazole. Good. And again, both of these are inhibiting the formation of ergosterol, which is important in cell membrane stability. So terbinafine and azoles inhibit ergosterol formation. All right, which ones actually bind with ergosterol, kind of form a pore because it has a hydrophilic and a hydrophobic portion. And when it binds to this ergosterol, it creates a little pore that allows for ions to move in and out, which can create the opportunity for cell lysis. This is, which ones do you guys remember? Which is the ones that actually form the pores? These are the ones like nystatin and amphotericin B. All right, beautiful. All right, so the next thing is we're going to move on to the drugs that inhibit the beta-1,3-glucan synthase. This is the guy that makes the beta-1,3-glucans, which are important in cell wall stability, resistance to osmotic forces. If we inhibit this particular enzyme, that will actually reduce the formation of these cell wall structures and reduce the ability to resist osmotic forces, causing cell death. This will be the echinocandins, mycofungin, caspofungin, right? Beautiful. All right, which is the ones that actually binds to the microtubules, particularly the tubulin proteins, inhibits the microtubules, so now that you can't actually separate the chromosomal DNA and help with the actual division of fungi passing on genetic material. This is griseofulvin. Beautiful. I know you guys are killing it. All right, which is the one that actually comes into the cell, gets converted into 5-fluorouracil cytosine deaminase, binds with the actual DNA, inhibits it from being able to undergo DNA replication and also DNA transcription. This is flucytosine. Beautiful. All right, we move on now into the first case. He says, okay, you have a patient who has oropharyngeal candidiasis. They got some thrush there. What's the treatment? What are the actual opportunities of what kind of drugs would you use? You can say, oh, you can use the nystatin, you can swish and swallow, or the clotrimazole lozenges. Beautiful, done. All right, he says, okay, you actually have a patient who has esophageal candidiasis, and you see this here. Look at all that. Oh, man, that's rough. What are you going to do for this patient? This is oral fluconazole or itraconazole. Beautiful. All right, you have a patient who has vulvovaginal candidiasis. What are the treatment options for this one? Well, first one we can consider is the topical azoles, the imidazoles, so type of topical meconazole, topical clotrimazole, and if that doesn't work, PO-fluconazole, and if that doesn't work, flucytosine. You guys remember this, right? All right, beautiful. All right, patient has intertriginous candidiasis, meaning that they have some candida in the actual different folds, like underneath the breast, in the axilla, in the anal genital area. What would a potential treatment for this be? We could do nystatin topical. Beautiful. All right, we have a patient who has systemic or invasive candidiasis. It's invaded their blood. So it's in their systemic circulation. It's caused endocarditis. It's caused a urogenital tract infection. It's caused an ocular infection, some type of nasty invasive candidiasis. What are the particular treatment options for these patients? You can do which one? The echinocandins are going to be really good at this, but you can also consider like PO-fluconazole as well, right? And last but not least, amphotericin. All right, you have a patient who has invasive aspergillus. So aspergillus is a nasty thing that can cause like allergic bronchopulmonary aspergillus. Then it can actually cause like a pneumonia, like a nodular kind of pneumonia. It can cause aspergillomas, like these fungal balls that can actually appear. And it can really cause cavitations and can even spread throughout the body. What would be the particular treatment options for this? What's always the first line? Voriconazole. Yep. Then isovuconazole, echinocandins, and amphotericin B is another option. All right, patient has a cryptococcal meningitis and pneumonia. What are the particular treatment options? So you treat this within the first 2 weeks, induce them with flucytosine and what else? Amphotericin B, and then after that, we can put them on fluconazole for after that 2 weeks as maintenance therapy. You guys remember that? All right, cool. We have a patient who has what's called either blastomycosis or histoplasmosis or coccidiomycosis. And as we talked about, this is kind of an endemic type of fungal infection that's dependent upon the geographical location that you're at. So as you can see, histoplasmosis would be in this part of the actual US, and you can see blastomycosis in this part of the US. And then again, you can see coccidiomycosis over here in this particular part of the US. So it's obviously dependent upon the geographic location, but either way it can cause, pneumonia, meningitis, skin, bone infections. So because of that, what are the particular treatment options for blasto, histo, or coccidio? What is it? Itraconazole is first line. Fluconazole is another option. And then if you can actually consider adding on amphotericin B to fluconazole, especially in those severe refractory cases. All right, patient has rhinocerebral and lung mucormycosis, really nasty type of infection. If they have this, people who are at high risk for this is patients who are diabetic or HIV positive. In this situation, what's the preferred treatment for mucor? It would be isovuconazole. That's first line. Other ones would be amphotericin B if they're contraindicated of taking isovuconazole. And then you need to consider debridement of the actual infected area. All right, patient has tinea versicolor. If they have tinea versicolor, right, this type of dermatophyte infection, what do you treat these patients with? Topical, ketoconazole would be the preferred one, or miconazole. All right. You have a patient who has a terrible day. They have tinea capitis, tinea corporis, tinea cruris, and tinea pedis. Right? So they have an infection of this actual nasty fungus on the head. They have it on the body. They have it at the growing. Okay, and they even have it of the feet. If this happens, what is the particular treatment for these patients? In a theoretical world, we would treat them with topical agents first: miconazole, clotrimazole, ketoconazole. We could even escalate to PO itraconazole. And then if that doesn't work, we can even consider something like griseofulvin. Now, if a patient has tinea unguium or what's called onychomycosis, this is a really nasty infection that will not respond to topicals. And really the only thing is PO terbinafine, and some even say griseofulvin, but terbinafine would be the preferred option. All right, engineers, we covered all of the cases that I want you guys to remember for your antifungals. I hope this made sense. I hope that you guys enjoyed it. As always, love you, thank you, and until next time.